Dear colleagues, dear organizers, thank you so much for giving me the opportunity to give a keynote lecture about the role of the immune system in psychiatric disorders and their therapy here at the Congress of the Royal Australian and New Zealand College of Psychiatrists. This is a great honor for me. My name is Hubertus Himmerich and I am a clinical senior lecturer in eating disorders at King's College London. I do my clinical work as a consultant psychiatrist at the Bethlehem Royal Hospital on an inpatient ward for people with eating disorders. The Bethlehem Royal Hospital belongs to the South London and Maudsley NHS Foundation Trust, and it is the oldest psychiatric institution worldwide. It was founded in 1247, and its history has inspired several horror books, films and TV series. In this talk, I'll focus on cytokine research in psychiatric disorders and their therapy, because cytokines have been my core interest during my time at the Max Planck Institute of Psychiatry in Munich, at the university hospitals in Aachen and Leipzig, and continue to be my main research topic at King's College London. After some historical remarks, I'll explain some basic immunological principles. Afterwards, we'll hear about the causes and consequences of changes in the cytokine system. As I cannot cover all the psychiatric disorders and their associated immunological changes, I'll present some own data on cytokine levels in people with depression and in patients with anorexia nervosa. There are already some therapeutic applications of cytokine research in psychiatry, for example, for specific subgroups of depressed patients, such as people with depression and autoimmune diseases, or patients with depression and obesity. I'll also outline a vision for the future, how we might use cytokine blockers in the treatment of treatment-resistant depression and in anorexia nervosa. Without knowing it, we might already make use of the beneficial immunological effects of psychopharmacological agents and of psychotherapy in our daily clinical practice. I'll elaborate on this idea before I summarize and conclude this talk, and then you will have the opportunity to ask any questions you might have. I think I should warn you that I did not only use PubMed and ISI of Science listed articles and own data to prepare this talk. I also had a look at some 19th century German textbooks, but I recognized that we should give some credit to some ancient colleagues as well. Even though Hippocrates didn't know anything about immune cells or cytokines, he observed clinical phenomena which can be explained by the connection between the immune system and the nervous system. For example, he observed that epileptic patients who became infected with malaria were cured from their epileptic illness. These might have been epileptic seizures caused by neurosyphilis, and we know that the spirochetes that cause syphilis don't survive feverish temperatures. Galen of Pergamon confirmed the connection between epilepsy and malaria and called the transition from one illness into another metaptosis. He also reported the positive effect of fever on psychiatric illnesses, such as lethargy. However, Hippocrates and Galen did not provide any immunological or microbiological explanation for their findings. They saw fever as a key natural form of healing. They conceptualized fever as an increase in vital warmth, which boils up the imbalance of the four body fluids. In the 18th century, Fahrenheit and Celsius developed the mercury thermometer and the temperature scale. And in the 19th century, regular measurement of the body temperature was introduced to inpatient treatment by Karl Reinhold August Wunderlich at the University Hospital of Leipzig. Therefore, psychiatrists started to measure the body temperature of their inpatients too. Here you can see An example of a documentation of the body temperature for a patient with a psychotic disorder over 3 days from the end of the 19th century. And here we are in the 21st century, still measuring our patient's body temperature on a regular basis. For example, to monitor fever as a potential side effect within the first couple of weeks after the start of psychopharmacological treatment with clozapine, or to check for hypothermia as part of the risk assessment in malnourished patients with anorexia nervosa. I would like to specifically mention two pioneers of psychoimmunological research in psychiatry, Emil Kraepelin and Julius Wagner von Jauregg. Emil Kraepelin is known for laying the foundations of our modern classification of mental disorders. However, he was also interested in the connection between acute inflammatory disorders and affective symptoms. In his habilitation, which he submitted in 1882, he already wrote about low mood in people with acute joint rheumatism. I later explain what our current hypotheses are regarding the underlying mechanisms. However, we should keep in mind that psychiatrists like Kraepelin were already aware of the fact that diseases like rheumatoid arthritis can cause affective symptoms. The Australian psychiatrist Julius Wagner von Jauregg is probably the greatest psychiatric psychoimmunologist of all time. Here you see a beautiful picture of him sitting on a sofa with 4 cushions, and look at these lovely tulips. In 1927, he was awarded the Nobel Prize for Medicine for his observation that artificial infection with malaria is an effective treatment for progressive paralysis, which is a complication of neurosyphilis. But he also discovered that febrile diseases might have a beneficial effect on psychiatric disorders. For example, in this table, where he listed patients with a psychiatric disorder who acquired a febrile disease, you can see that most of the patients with a manic episode or with a psychotic disorder achieved full recovery in temporal connection with the inflammatory disease. Thus, Kraepelin's and Wagner von Jauregg's scientific work, conducted at the end of the 19th century, had already indicated that the immune system is involved in the pathophysiology of psychiatric disorders and is a target structure for the treatment of psychiatric disorders. Due to the development of modern optics, dyeing and counting methods for cells, physicians became able to determine the number of cells in a certain volume of blood in the first half of the 20th century. Therefore, psychiatrists started to do cell counts in the blood of their patients. This is an example of a blood count by Dr. Ostman in the year 1928 in 213 patients with schizophrenia. Nowadays, we use flow cytometry to count cells automatically. Using this technique, we can distinguish between different subtypes of cells by marking surface molecules of these cells with fluorescing antibodies. To understand how the immune system works, it was also essential to be able to measure signal molecules that immune cells use to communicate with each other. These signal molecules are called cytokines, and they can be measured using a radioimmunoassay or an enzyme-linked immunoassay. The radioimmunoassay was invented by Solomon Aaron Burson and Rosalind Sussman Yalow. For this invention, Rosalind Sussman Yalow received the Nobel Prize in 1977. By the way, the first molecule she measured using a radioimmunoassay, as you can see in this slide, was insulin. The immune system is defined as the biological defense system of higher organisms, which can prevent damage from pathogens. The immune system is divided into the innate and the adaptive immune system. The innate immune system can fight pathogens without a previous contact with them. The tasks of the innate immune system are performed by granulocytes, monocytes or macrophages, dendritic cells and natural killer cells. In the central nervous system, cytokines are produced by astrocytes and microglia cells. These cells modulate the further immune response by interacting with naive T helper cells, the Th0 cells you can see in the middle of this figure, and by producing cytokines. Important cytokines boosting an inflammatory process are, for example, the acute phase cytokines interleukin-1, interleukin-6 and tumor necrosis factor alpha. The adaptive immune response is characterized by the ability to target new pathogens specifically. The cells of the adaptive immune system include cytotoxic T cells, B lymphocytes and T helper cells. According to their cytokine secretion pattern, T helper cells can be divided into two subpopulations, the T helper 1 cells and T helper 2 cells. T helper 1 cells secrete primarily interleukin-2 and interferon gamma. Important T helper 2 cytokines are interleukin-4, interleukin-5 and interleukin-10. The T helper 1 response activates cytotoxic T cells, whereas the T helper 2 immune response leads to the production of antibodies. Two recently discovered important elements of the immune system are regulatory T cells and T helper 17 cells. Regulatory T cells prevent an excessive immune reaction, whereas T helper 17 cells support inflammatory processes. Within this talk, I'm going to focus on interleukin-1, TNF-alpha, interleukin-6, and regulatory T cells. I would like to give an example how this system works. During this pandemic, a COVID-19 virus infection is not far to seek. In fact, I'm currently staying in the UK to reduce your risk of being infected with the UK variant of the virus. Now, if you inhale the virus, the pulmonary epithelial cell is the first physical barrier for the virus. However, using a spike protein, it can interact with the angiotensin-converting enzyme 2 receptors and the specific transmembrane protease, enter the epithelial cell and destroy it. But sooner or later, the virus will be recognized by so-called toll-like receptors on the surface of sentinel cells, for example macrophages. And these cells will immediately start the production of interleukin-1, interleukin-6 and TNF-alpha. Furthermore, the macrophages will interact with naive T helper cells to activate cytotoxic T cells to initiate the cellular immunity, or to activate B lymphocytes to produce antibodies. During this COVID-19 infection, various types of immune cells produce a range of cytokines, such as TNF-alpha, interleukin-6, interleukin-1, interleukin-17 and interferon gamma. We have seen that an infection can cause increased cytokine production. But what are other reasons potentially relevant for psychiatry? What about stress? To answer this question, we investigated the cytokine production of male Vista rats during 3 different kinds of stress. The rats had to put up with either acute stress, with chronic stress, or with stress due to social isolation. For the induction of acute stress, we used the forced swimming test. For the induction of chronic stress, the animals were locked into a tube for 4 hours a day, and social isolation was performed by single housing. After each of the 3 stress paradigms, interleukin-2, interleukin-4, interleukin-6, 10, 22, TNF-alpha and interferon gamma were detected in the blood of the rats. I would like to mention that the forced swim test is not only capable of inducing acute stress, It is also a test to evaluate the efficacy of an antidepressant agent. During the first swim test to test antidepressant efficacy, the rat is placed in such a water tank. Happy rats make quite a lot of swimming movements. In contrast, the time of immobility is a measure of hopelessness and depressiveness of animals. Effective antidepressants reduce the time of immobility in the first swim test. As you can see in this slide, acute stress in the first swim test, as well as chronic stress in the restraint stress paradigm, induced significant increases in the plasma concentrations of interleukin-4, interleukin-6, interleukin-10, and tumor necrosis factor alpha. To test the reaction of cytokines to social isolation, we kept the Vista rats either in a group of 4 animals in one cage or alone in one cage, which is called single housing. As rats are social animals, single housing means a lot of stress to them. This is comparable to a lockdown during a pandemic for human singles. Thus, this is an animal lockdown model if you wish. The rats that were individually housed showed a lower body weight after 4 weeks compared to rats housed in groups. Individually housed animals also had elevated ACTH plasma concentrations, which shows that a biological stress system, the hypothalamic pituitary adrenal axis, or in short HPA axis, is activated. The individually housed rats also showed increased interleukin-4, interleukin-10 and TNF-alpha plasma concentrations, similar to the animals that were acutely or chronically stressed during the first swim test or the chronic restraint stress. Regarding the question what influences cytokine production, I would briefly like to mention a study we conducted at the Integrated Research and Treatment Center for Adiposity Diseases in Leipzig. We included 200 participants, 107 were obese patients, 83 were non-obese community-based volunteers. In this study, we measured the serum concentrations of a broad range of cytokines and determined weight, height, waist hip circumference, as well as physical activity. The main findings were higher serum concentrations of interleukin-5, interleukin-12, and interleukin-13 in obese patients. These results were not unexpected because we know that fat cells themselves, but also macrophages which invade the adipose tissue, produce cytokines. Interestingly, physical activity was associated with low levels of a number of cytokines, even in obese patients. Therefore, if we take into account that cytokines are involved in the pathophysiology of the physical consequences of obesity, such as diabetes, this might be a great message for obese people, because by being physically active, they may be able to prevent the negative consequences of obesity. I have already showed you data which indicate that infections, acute, chronic, and social stress, as well as obesity, lead to increased inflammatory cytokine production. Further conditions where cytokines are overproduced include autoimmune diseases, cancer, physical trauma, smoking, drug abuse, environmental factors like air pollution, oxidative stress, hormonal changes, changes in the gut microbiome, and disturbances of the sleep-wake rhythm. These risk factors for changes in cytokine production have interestingly all been found to be risk factors for mental disorders. Before we proceed to the question how cytokines can influence the brain, I would like to comment on the differences between cytokines, neurotransmitters, and hormones. Neurotransmitters are signaling molecules for synaptic signaling. For example, in a serotonergic synapse in the prefrontal cortex, a neurotransmitter is released by the presynaptic neuron It travels about 30 nanometers until it finds its postsynaptic receptor. This is quite an easy way of signaling, isn't it? Another kind of signaling is hormone signaling, for example ACTH signaling. We have already heard about ACTH levels in stressed rats. ACTH is the adrenocorticotropic hormone. ACTH is produced in the pituitary gland and released into the circulation. It follows the bloodstream to the cortex of the adrenal glands. If it binds to its receptor, the production of glucocorticoids is stimulated. This is a bit more difficult than neurotransmitter signaling because ACTH has to go on a journey through the whole circulation. Now, what about cytokine signaling? Cytokines like TNF-alpha can be produced by microglia anywhere in the brain or by macrophages anywhere in the body. Cytokine-producing cells are not attached to one locality. They move about freely. I just mentioned TNF-alpha. Every single cell on our body carries TNF-F receptors type 1 on its surface. Thus, cytokine signaling goes from anywhere to everywhere in the body. Thus, if you see research papers where people like me have measured TNF-alpha in the blood, please keep in mind that nobody knows where this TNF-alpha comes from and where it will unfold its most significant effects. It is important to know how peripherally produced cytokines can influence the brain. In the periventricular regions are physiological gaps in the blood-brain barrier. Additionally, various diseases such as stroke can cause pathological gaps. Through these gaps, cytokines may find their way from the blood into the central nervous system. Neuronal connections are also described. Afferent nerve fibers of the vagus nerve have cytokine receptors, for example, interleukin-1 receptors. Thus, the information that is conveyed by cytokines can be brought to the brain by the vagus nerve. Additionally, there is a cellular pathway how cytokines can enter the brain tissue. The microglia can produce monocyte chemoattractant protein 1, in short MCP1. MCP1 leads to the recruitment of monocytes from the blood into the brain, and these monocytes will produce cytokines within the brain. To sum up, cytokines can enter the brain using humoral, neural and cellular pathways. Meanwhile, it is known that almost every cytokine can be produced in the brain, and there are also specific receptors for almost every cytokine in the brain. Okay, we have now talked about basic principles of the immune system, about cytokine signaling and how cytokines can influence the brain. Let's now move to specific psychiatric disorders. In this study we conducted at the Max Planck Institute of Psychiatry in Munich, we investigated the plasma concentrations of TNF-alpha and its soluble receptors, P55 and P75, in subjects who were never depressed, in people with depression in their medical history, and in acutely hospitalized patients with depression but without any inflammatory disease. As you can see in this figure, patients who were never depressed had the lowest concentrations of TNF-alpha and its soluble receptors. Subjects with depression in their medical history had somewhat higher concentrations, and the highest concentrations of TNF-alpha and its receptors were found among the 70 acutely depressed patients. Therefore, we can assume that TNF-alpha may be involved in the pathophysiology of depression. In another study with 62 depressed patients and 210 non-depressed subjects at the University Hospital of Leipzig, this result could be replicated. Depressed patients and controls differed with respect to their plasma levels of TNF-alpha. Additionally, they showed higher levels of the T helper 1 cytokine, interferon gamma, and granulocyte and monocyte colony stimulating factor. The plasma concentrations of the T helper 2 cytokine interleukin 10, however, did not differ between depressive patients and controls. It is worth mentioning that obesity had a significant influence on cytokine levels in these depressed patients. One of the factors linking obesity to depression may be the overproduction of inflammatory cytokines in the fatty tissue. Therefore, obesity and increased cytokine production plus depression could constitute a specific subtype of depression. On the molecular level, cytokines affect various biological mechanisms which are known to be involved in the pathophysiology of depression. TNF-alpha, for example, activates the reuptake of neurotransmitters such as serotonin and thus acts inversely compared to antidepressants. It also activates the indolamine 2,3 dioxygenase. Therefore, under the influence of TNF-alpha, tryptophan is metabolized to kynurenine and is thus no longer available for the synthesis of serotonin. Furthermore, TNF-alpha activates the hypothalamus-pituitary-adrenal axis and potentially contributes to autoimmune destruction of neurons. These cytokine effects could explain the association between inflammatory diseases and affective symptoms reported by Emil Kraepelin. Cytokines which are known to modulate mood also influence certain endocrine systems. TNF-alpha, interleukin-1, interleukin-6, and interferon gamma, for example, activate the HPA axis. Interleukin-1, interleukin-6, and interferon gamma additionally inhibit the hypothalamus-pituitary-thyroid axis. And we all know that core symptoms of hypothyroidism are loss of energy or depressed mood. Additionally, interleukin-6 and interferon gamma inhibit the growth hormone axis, and all these endocrine changes are known to be associated with depression. If we use our map of the immune system and recap what has been found in depression, we can summarize that we have activated macrophages and monocytes in the body, and these cells may be in the blood, the fatty tissue, or the lymphatic organs. We have activated microglia and astrocytes in the brain, as the brain is closely connected via a humoral, nerval, and cellular pathway. Furthermore, several kinds of T helper cells are activated, and all these cells produce interferon gamma, interleukin-1, interleukin-6, and tumor necrosis factor alpha, and lead to inflammatory processes. And these inflammatory processes will increase the risk for organic comorbidities of depression, for example, type 2 diabetes or myocardial infarction. Cytokines do not only influence mood, but have also been reported to affect appetite regulation. They have been implicated in the regulation of energy homeostasis and expenditure, the control of appetite and food intake, the metabolic rate, food preferences, and taste aversion. They have been reported to reduce meal size, meal duration, and meal frequency, to lead to stomach muscle contractions and decreased NPY levels. NPY is an orexigenic hormone produced in the hypothalamus. In contrast, inflammatory cytokines have been found to increase intermeal intervals, to influence the glucose metabolism, to enhance resting energy expenditure, and to raise cortisol levels. Therefore, we thought cytokines may also be involved in the pathophysiology of anorexia nervosa, and we measured a range of cytokines in an exploratory study in 27 people with anorexia nervosa and 13 age-matched controls. In our sample, BDNF levels were reduced in accordance with other studies. Other decreased inflammatory markers were tumor necrosis factor beta and VEGF-A, which is a vascular growth factor. The serum levels of the cytokines interleukin-6 and interleukin-15 and the adhesion molecule VCAM were increased. Previous studies had already found increased interleukin-6 levels in patients with anorexia nervosa, as this meta-analysis shows, which was performed by my previous PhD student Bethan Dalton. In this diagram, 0 is the line of no effect, and points to the right of the 0 line indicate an elevation of interleukin-6 in people with anorexia nervosa compared to healthy controls. As you can see, with one exemption, all other studies found an elevation of interleukin-6 in people with anorexia nervosa. However, the question was whether elevated IL-6 levels are a state or a trait marker of anorexia nervosa. Therefore, we followed our 27 patients with anorexia nervosa for 12 weeks of treatment, and we found a significant decrease in IL-6 levels after 12 weeks. Thus, IL-6 levels seem to normalize when people are on their way to recovery. 2 years ago, we summarized the meta-analyses on cytokine levels in various psychiatric disorders, and what we found was that affective disorders, psychotic disorders, PTSD, OCD, and anorexia nervosa are associated with characteristic changes in cytokine levels. Thus, psychiatric disorders seem to have their characteristic pattern of cytokine changes. Now the question is, how can we apply this knowledge in clinical practice? Given the possibility that cytokines might mediate the pathophysiological pathway from stress, infection, or obesity to the development of depression, it would be interesting to test drugs which block the cytokine action. In this respect, TNF-alpha antagonists are available. These drugs are already approved for the treatment of a number of inflammatory diseases such as psoriasis. Psoriasis patients often have depressive symptoms. In a study by Tyring from the University of Texas, published in The Lancet in 2006, 30% of examined psoriasis patients were depressed. The study participants were treated for 12 weeks with 50 mg etanercept, a TNF-alpha blocker, or placebo. There was a significantly greater improvement in the Hamilton Depression Rating Scale and the Beck Depression Inventory, and a significantly higher number of responders with respect to depressive symptoms under the treatment with etanercept. The improvement in the two depression scales did not correlate with the improvement in dermatological symptoms. Therefore, these results cannot be easily interpreted as a consequence of the improvement of the physical disease. This figure shows the changes in the Beck Depression Inventory under etanercept versus placebo, and you can easily recognize the significant improvement during etanercept treatment compared to placebo. During my time as a liaison psychiatrist for the dermatology and orthopedics department at the University Hospital in Aachen in Germany, I experienced many times that the mood of depressed patients with psoriasis or rheumatoid arthritis improved considerably during treatment with cytokine blockers, even without additional antidepressant treatment. Thus, this might be an antidepressant treatment option for people with depression and an inflammatory condition for which cytokine blockers are approved. As obesity and depression co-occur in a significant proportion of the population, and cytokines might link the two disorders together, we did a systematic review to check whether longitudinal clinical trials testing a dietary intervention in people with obesity and depression would lead to improvements in the mood of these people. 24 longitudinal clinical studies met our eligibility criteria, and we found that calorie-reduced diets resulted in a decrease in depression scores with effect sizes between 0.2 and 0.6. The results were less clear for dietary supplements. Therefore, people with obesity and depression might constitute a specific subgroup of depressed patients in which calorie-restricted diets might be a promising, personalized treatment approach. Amongst other endocrine and psychosocial reasons, a calorie-restricted diet might reduce inflammatory cytokine production within the fatty tissue and thus reduce the negative impact of inflammatory cytokines on the brain. Physical activity might have a similar effect, as we could show that it reduces inflammatory cytokine production in people with obesity. Therefore, physical activity is something we should recommend to our patients with obesity and depression, and we should of course help them to start getting physically active. This figure gives you an idea of how many steps normal weight subjects and obese people walk per day. In this study we found that the average amount of steps taken by day differed significantly between healthy controls, obese subjects, and obese subjects who also suffered from depression. Normal weight controls walked on average about 12,000 steps per day, obese patients walked about 7,000, and obese and depressed made only 6,000 steps on average per day. Now let's move to potential future treatment options that might target specific components of the immune system. I already introduced you to our Vista rat experiments. In this study we examined possible antidepressant-like effects of the TNF-alpha antagonist etanercept. This is the same TNF-alpha blocker that Tyring and colleagues used in their study with people who suffered from psoriasis and depression. The Vista rats were subjected to either a restrained or a non-restrained protocol for 5 weeks, meaning that one group of animals was placed in this plastic tube for several hours per day and the other group was not. Animals that had been subjected to the chronic stress paradigm received either ringer solution, etanercept, or imipramine from the beginning of the 3rd week until the end of the experiment. Imipramine is the standard antidepressant in animal experiments to study antidepressant efficacy. And these are the results in the first swim test. The black bars depict the immobilization time in the animals in the first swim test, which were subjected to chronic stress. You can see that the chronically stressed animals treated exclusively with ringer solution as our placebo condition had the longest immobility time. In contrast, the immobility time was significantly reduced by imipramine or by tumor necrosis factor alpha blocker etanercept. Therefore, in this animal experiment, with stressed rats, the tumor necrosis factor alpha blocker was successful in the therapy of a stress-induced depressive state. Thus, in this animal experiment, etanercept seemed to be effective to treat depressive symptoms, even though the reason for depression was chronic stress and not an underlying immunological condition. After these successful animal studies, we administered etanercept in 2 patients with difficult-to-treat depression. Patient number 1 was 62 years old, pensioned, and came to us with his 24th episode of depression. He had tried more than 10 different antidepressants without success. Patient number 2 was 58 years old, and in addition to the chronic depression, she suffered from alcohol dependence as well. She had also tried a wide range of antidepressants unsuccessfully. Both patients had not tolerated lithium, and electroconvulsive therapy was applied in both patients without success. Under the therapy with etanercept, 25 mg twice weekly, subcutaneously, a significant drop in the Hamilton Depression Score appeared in both patients, but unfortunately, The Back Depression Inventory, which is a self-rating scale, did not show a significant subjective improvement across the whole length of the therapy. Therefore, in these chronically depressed patients, etanercept did not help as good as we had hoped. As I had mentioned earlier, interleukin-6 has been found elevated in acutely affected patients with anorexia nervosa. Interleukin-6 levels normalized during treatment and may thus be a state marker of anorexia nervosa and involved in its pathophysiology. As inhibitors of the IL-6 signaling pathway, such as tocilizumab, are frequently administered for the treatment of immune diseases, such as rheumatoid arthritis, we were wondering whether these medications have any influence on body weight in these patient groups. Therefore, we performed a meta-analysis to ascertain the effects of interleukin-6 pathway inhibitors on weight and body mass index. We could include 10 studies with a total of 1,531 patients in the meta-analysis for weight changes, and we identified 10 studies with a total of 1,537 patients suitable for the BMI meta-analysis. The most commonly administered IL-6 pathway inhibitor in these studies was tocilizumab, and overall we found that the IL-6 pathway inhibitors were associated with significant increases in weight and BMI. Thus, we concluded that the IL-6 signaling pathway seems to be involved in body weight regulation, and that modulating IL-6 signaling may be a potential future adjunct for the treatment of disorders associated with weight changes such as cancer, cachexia, and anorexia nervosa. I have already showed you that cytokine blockers have antidepressant properties in animal studies and that these anti-inflammatory drugs have important effects on psychiatric symptoms such as mood and food consumption in people with autoimmune diseases. Therefore, we asked ourselves what effect psychopharmacological drugs might have on the immune system and whether these effects might contribute to their beneficial effects in people with affective or psychotic disorders. More specifically, we wanted to know whether antidepressants could downregulate cytokine production. For this reason, we investigated the effects of several antidepressants on interferon gamma production. We stimulated blood of 6 healthy subjects to produce cytokines using toxic shock syndrome toxin 1, abbreviated TSST1, in a whole blood assay. TSST1 is the toxin of Staphylococcus aureus bacteria. Afterwards, we measured interferon gamma levels in the stimulated blood. Additionally, the blood was either supplemented with antidepressants or not, and as antidepressants we used venlafaxine, O-desmethylvenlafaxine, amitriptyline, nortriptyline, imipramine, or desipramine. The interferon gamma concentrations differed statistically significantly between blood with and without antidepressants. The tricyclic antidepressants amitriptyline, nortriptyline, imipramine, and desipramine significantly reduced interferon gamma levels. A trend, but no significant difference, was found between the control condition and the venlafaxine or O-desmethylvenlafaxine condition. Therefore, it may well be that the antidepressant effect of tricyclic antidepressants is mediated by a downregulation of the production of cytokines like interferon gamma. The beneficial effect of amitriptyline on chronic pain may also be partially explained by its anti-inflammatory effects, because our perception and experience of pain is massively influenced by cytokine signaling. Even though not all in vivo and in vitro studies are 100% consistent, most of the in vivo and in vitro studies show a reduction of cytokine production under the treatment with antidepressants. The next question is, how can antidepressants influence immune cells in order to modify the production of cytokines. As regulatory T cells are able to reduce cytokine production, we got the idea that antidepressants could influence the activity of regulatory T cells, which in turn would inhibit inflammatory cytokine production. Therefore, we performed a small study in 16 consecutive referrals to the Department of Psychiatry and Psychotherapy of the University Hospital in Aachen, suffering from a depressive episode. These patients did not have any acute or chronic inflammation or infection, autoimmune, cardiac, pulmonary, endocrine, or hematological disease. These depressed patients were then treated with different kinds of antidepressant drugs according to their doctor's choice. Blood samples were drawn and psychopathology was assessed within the first week of treatment after admission and after 6 weeks of treatment. Patients' psychopathology was assessed using the Hamilton Depression Scale. Within the blood, we determined plasma levels of interleukin-1 and the concentration of regulatory T cells. For the detection of regulatory T cells, we used flow cytometry. The table shows the synopsis of the study results. The Hamilton score decreased, the IL-1 and IL-6 plasma levels dropped, and the percentage of regulatory T cells increased significantly. Now, our theory is that the antidepressants increase the amount of regulatory T cells, which suppress cytokine production, and the reduction of IL-1 beta and IL-6 led to a significant improvement of the depressive psychopathology as measured by the Hamilton Rating Scale. Taken together, this is what antidepressants do. They upregulate regulatory T cells, they downregulate interleukin-1, interleukin-6, TNF-alpha, and interferon gamma, and these effects result in a relaxation of inflammatory processes within the body. Regarding antipsychotics, we found in an in vitro study that all tested antipsychotics, chlorpromazine, which was the first antipsychotic, clozapine, desmethylclozapine, the major active metabolite of clozapine, haloperidol, and quetiapine increased interleukin-17 production. In an in vivo clinical study in 15 patients on clozapine and 15 patients on olanzapine, we found an increase in TNF-alpha production under both medications. Interestingly, patients who developed fever as a side effect of the clozapine treatment showed the highest TNF-alpha concentrations in their blood. This may remind us of Wagner von Jaureg's experiments, who induced fever to treat patients with psychotic disorders. The immunological mechanisms underlying the treatment with a highly potent atypical antipsychotic clozapine, which is even used for treatment-resistant schizophrenia, might be similar to those therapeutic mechanisms Wagner von Jaureg used by injecting psychotic patients febrile-facient pathogens. This figure summarizes the immunological effects of antipsychotics. They upregulate Th17 cells, they increase the production of interleukin-1, interleukin-6, interleukin-17, and TNF-alpha, and this may lead to inflammatory processes within the body. From this perspective, it is no wonder that immunological side effects associated with inflammation may occur during the treatment with antipsychotics, such as fever, leukocytosis, acromegalycytosis, type 2 diabetes, and increased photosensibility. I would also like to briefly mention that not only psychopharmacological treatment leads to immunological changes, but also psychotherapy. For example, in this study, we found changes in the TNF-alpha system during psychotherapy for soldiers with post-traumatic stress disorder. Before I summarize my talk, I would like to point out some limitations of cytokine research in psychiatry. If we measure cytokines in the serum or plasma of psychiatric patients, we do not know where these cytokines come from, which cells produce the cytokines we measure, and what the natural target of these cytokines are. The cytokines may target immune cells, the brain, or cells in the blood. We don't know all the causes for the cytokine changes and what all their effects are. However, it has meanwhile become accepted in the scientific community that low-grade inflammation is associated with mental disorders and physical health consequences such as insulin resistance and diabetes. In order to start summarizing my talk, I would like to mention again that Emil Kraepelin had already recognized a connection between acute inflammatory disorders and affective symptoms, and that Julius Wagner von Jaurek had observed that febrile diseases can have a beneficial effect on psychoses. Changes in the cytokine system may be due to infections, autoimmune diseases, cancer, physical trauma, smoking, drug abuse, hormonal changes, obesity, and changes in the microbiome. Psychiatric disorders have been shown to be associated with cytokine changes. Examples of such mental disorders are depression, anorexia nervosa, schizophrenia, bipolar disorder, and post-traumatic stress disorder. Currently, possible therapeutic applications are the use of TNF-alpha blockers for people with depression and anti-immune diseases, or a calorie-restricted diet, or enhanced physical activity for people with depression and obesity. Potential future treatments might include TNF-alpha blockers in treatment-resistant depression or interleukin-6 pathway inhibitors in anorexia nervosa. Immunological effects of psychiatric therapies include an upregulation of regulatory T cells and a downregulation of interleukin-1 and IL-6 production during the treatment with antidepressants, and an upregulation of TNF-alpha during the treatment with clozapine and olanzapine, and an upregulation of interleukin-16 caused by a range of antipsychotics in vitro. Psychotherapy has also been reported to lead to complex changes in cytokine signaling. Even though it is relatively easy to measure cytokine levels in the serum, the challenge is to interpret the results in psychiatric patients. Finally, I would like to thank my colleagues in Leipzig, Berlin, Aachen, Munich, London, Coventry, and Hobart for their help and support. And I thank you for your attention, and I'm happy to answer any questions you might have. Thank you.